Good morning, good afternoon, good evening, everyone. Today we'll be talking about dental hygiene in CDKL5 and other rare disorders. Our, this webinar is hosted by CDKL5 South Asia, dedicated to finding cure and support for families impacted with CDKL5 in the South Asian region. And our tech partner is IndoUSrare. Our guest speaker today is Dr. Manpreet Grewal. Dr. Manpreet Grewal graduated with honors from University of Manitoba with DMD and BSc degrees. Dr. Grewal was awarded Sophie Kennan Memorial Prize in Dental and American Association of Public Dentistry Award for her outstanding achievements. She is an expert in many dentistry fields and has extensive training and continues to educate herself in all new technologies and dental advancements. Dr. Grewal has been involved in dental research as well, and she loves cooking. Uh, she's whipping up new recipes in the kitchen, as well as uh, uh, enjoys spending quality time with her husband Shamsher, and she has two young daughters, Avnoor and Arjohi, and a lovely son, Arjnavir. And we are very glad and excited for today's talk. So with that, just quick housekeeping. Please put your questions in the QA section, and if there is anything you need Dr. Grewal to clarify while the presentation is on, just raise your hand virtually, and we can take a minute to elaborate on that topic. So as I mentioned, IndoUSrare is our technology sponsor, and they have this upcoming webinar. I'll hand it over to Nisha. Sorry, they have this upcoming summit. I'll hand it over to Nisha to talk.
Thanks, Jainu. Hi, everyone. Good evening, good morning to everyone. It's an honor to partner with CDKL5 South Asia for this very insightful webinar. And we hope you all find it as informative and exciting as we are looking forward to. Like Jainu said, the Indo-US Organization for Rare Diseases, we are a nonprofit based out of Virginia, US. And our mission is to bridge nations to empower rare lives. We make connections between all stakeholders for rare diseases so that we can accelerate access to therapies, both existing and upcoming, for all rare disease patients, with a particular focus on people from the Indian diaspora. Our upcoming annual conference, the Indo-US Bridging Rare Summit, is scheduled for November 16th through 18th of this year in New Delhi. It's a hybrid event. The in-person is at the Indian National Science Academy campus in New Delhi, and everyone can attend it on the virtual platform as well. This is so that we can enable access from all across the world. Covers a wide variety of topics ranging from ongoing standard of care to upcoming therapies and regulatory aspects. And we invite all of you to please check it out. The agenda and our exciting lineup of speakers, including Dr. Peter Marks from FDA and Dr. Dave Pierce from ERDC. Summit.indousrare.org is our website. And without further delay, I would like to hand it over to Jainu to take it forward for our today's presentation. Thank you all for joining in.
Thank you, Nisha. That was very informative. Dr. Manpreet, please get started. And yeah.
Hi, everyone. Thank you all for joining us on this lovely Sunday morning. I hear it's a little bit earlier for most people. It's 9 a.m. here. So thank you all for taking the time to go over this really important content that we're going to cover today. Jeannie, will I have control over clicking through the presentation?
You can just let me know, and I'll go on to the next slide.
Okay, because it's one by one.
Yes.
So I'll just say next, and then you can keep going. Okay,
yes.
Go ahead and go to the next one.
Yes.
Yeah, go ahead. Yeah, and you can load the entire screen there. Yeah, that would be good. Okay. Perfect. Then I'll go through everything at once. And then one more click. All right, so I want to start off by thanking Janie for reaching out and giving me this opportunity to share this with our CDKL5 family. And I understand there are other individuals from other rare disease families as well, so welcome to everyone. A little bit about myself to start off with. I live in Ontario, Canada with my beautiful family. I have 2 girls and 1 little guy, 8, 5, and 1. And I graduated from University of Manitoba in 2013, so I've been practicing general dentistry for the last 11 years or so, and currently I practice dentistry in Brampton, Ontario. And our focus for our offices is primarily on comprehensive family dentistry. So we see young children, we see elderly patients, and everything in between. And ever since I became a mom, my approach has become more prevention focused. So it's not just about treating dental diseases, it's also about educating our parents, patients about how to prevent these diseases from starting in the first place. And of course, our Joy, her lovely picture right there, she's the one that introduced us to the CDKL5 family. And I do want to start off by saying that, you know, our kids take a lot of our energy, and at times dental is not a priority. I understand that many days we're just trying to control the seizures and deal with the bigger issues, but there are, on a day-to-day basis, certain things that we can introduce and implement that will prevent them from, you know, having to undergo sleep dentistry to have the treatment done. So my goal here is to share some preventative techniques to help with that. Next, Gino. Okay, and then we can load up the entire screen there. There should be multiple points. This would be a lot easier if I knew how Zoom worked. So thank you for helping me with that. So today's agenda, when I was developing this presentation, I posted on our CDKL5 Facebook page and asked, you know, other moms, what are some questions that they have? And I used those questions to make a template of sorts to share the information for today. So if we can go back to the first slide there. So we're going to talk about when the first age of the dental visit should happen. This is based on the American Academy of Pediatric Dentistry and the Canadian Dental Association, and what exactly causes cavities, and what the risk factors are specific to CDKL5 for dental diseases, toothbrushing, and what type of toothpaste we should be using for our children.
It's so sweet. I don't know why.
Is everything okay? And the type and amount of toothpaste, and ketogenic diet and how it impacts the dental health, and teething and seizures, and everyone's favorite topic, bruxism, clenching and grinding. And then we'll have a question and answer period as well, okay? And next, Gino. We can load up that entire slide. Okay, so the age of the first dental visit, the Canadian Dental Association recommends that the first visit take place within 6 months of the eruption of the first tooth and no later than first year of age. It's important to understand that there is some conflicting information out there where they're recommending the first visit by age 3. In my opinion, that's too late. We have to follow the guidelines, which is by age 1, and this allows us to focus on parent education, establishing good oral hygiene habits, and identifying key risk factors that contribute to dental disease. And at that visit, we're brushing and polishing the child's teeth, we're counting teeth, and we're applying a fluoride varnish. The goal really is to make it a fun and a happy visit for the child, and establish that dental home, and not make it something where they have to be fearful. If we're waiting for you know, dental disease to set in and we're bringing them in by the time they're already in pain, then that changes their relationship for the worse over time. So we want to introduce it on a positive note. And then after that, based on the child's risk factors, their dentist would put them on either a 3 or 6 month recall schedule for maintenance. And next slide, Gino. And then we can load up that entire Okay, so etiology of cavities of the dental caries, it is multifactorial. It's not just one thing that leads to cavities. I've seen children from the same family where they're eating the same foods. One child is more prone to cavities, one child, never gets cavities. So it is important to understand that there's different things that put a child at risk, and there's different protective factors at play. Cavities is defined as a microbiological disease of the hard structure of the teeth. It's localized demineralization that's taking place on that tooth. So basically the minerals from the tooth are being leached out, which eventually turns into a cavity, a hole inside that tooth. So in order for a cavity to take place, we need the host, which is the tooth. We need a certain kind of bacteria inside the mouth for it to cause a cavity. We need a certain type of diet, which is going to work as food for the bacteria. And then all three of those have to be present for a significant amount of time for it to lead to caries. So it's not sugar directly that causes the cavities. What's happening is the digestion of the sugar. The sugar is a readily available food source for the bacteria inside our mouth. The digestion of the sugar leads to acidity inside the mouth. And then when that acid sits on the tooth, that leads to the demineralization, basically minerals leaving the tooth. And as I mentioned earlier, that eventually leads to a cavitated surface on the tooth, which continues to grow and eventually lead to infection or pain inside the mouth. So the critical pH when we're having acidic foods, sugary foods, once we've reached that pH inside the mouth of less than 5.5, that's when we're in a phase of demineralization. So one thing to keep in mind is that right after meals, we want to avoid brushing our children's teeth, because as soon as we eat something, our mouth is naturally in a state of acidity. We want to be waiting at least about 20 to 30 minutes after they've had a meal before we're brushing their teeth. And next slide, Jane. So the three categories that we covered, they each have, like I mentioned, protective factors and things that put us at risk. So when we're looking at the child themselves, the tooth anatomy really matters. So certain parts of the teeth, on the back teeth especially, they can have deeper grooves, which put them at more risk of cavity development because we're not able to brush those areas as well. We're not able to remove the plaque. And the positioning of the teeth. If the teeth are misaligned, meaning there's a lot of overlapping, we just can't get to certain spots, then they're naturally going to be at a higher risk of cavity development. The composition, the structural integrity of the tooth itself, the saliva quantity and quality that we have. So saliva is actually protective. It's the more saliva that we have, it's going to prevent the cavity formation, the body's own immune response, and of course their oral hygiene habits as well. The bacteria that contribute to cavities inside the mouth is S. mutans and lactobacilli, and we all have varying concentrations of these. So some people are more prone to having like higher numbers of these. Some people have lesser numbers of these. And it is important to realize that babies aren't born with this bacteria. So this bacteria is often transferred from caregivers through, sharing utensils, kissing, that type of thing. So we can minimize the transmission of this bacteria to our children as well. And diet, so the more high risk the diet is, such as refined sugar, starch, sticky foods, acidic foods and drinks, the more the child is going to be at risk of the cavities, because again, we're giving the bacteria that readily available food source so they can break that down into acid. The frequency of food consumption also matters. So the frequency, the more frequently we're having meals or having snacks throughout the day, it's not always the amount, it's the frequency, because each time we have, say, 2 Skittles, it's going to take about 20 minutes for the pH level to become to a normal baseline. So if you now have another meal or another candy 20 minutes later, then the mouth is in a constant state of demineralization. So we want to limit the frequency as well. Okay, and next slide, Janu. And we can just load that up, yeah. So some of the risk factors for dental disease, for CDKL5 and other rare diseases, is that our children are often not consuming the same diet as us or as our other children. So they do tend to have, from lack of ability to chew and things like that, they can have a poor nutritional profile. When the diet is softer, that's also leading to more plaque accumulation. The crunchier the foods are that we're eating, then naturally they're going to clean our teeth. So carrots are a great addition to lunch and things like that if your child is able to have them. And prolonged bottle use. So bottle use, we advise that after age of 12 months, not to have anything in the bottle other than water. But I know that is impossible with a lot of our children. That's their main source of nutrition. But keeping in mind that if they're falling asleep with the bottle in their mouth and that has milk or formula inside of it, that tends to drip onto their front teeth, which contributes to cavity development on those front teeth. And deficient vitamins and minerals due to use of anti-epileptic drugs. That we know certain medications really kind of leach out those minerals and vitamins from their bodies. And then crushed medication can lead to chemical erosion of the teeth. So our Joy, she doesn't take medications that are liquid. We do crush up her medications. And a lot of times these medications are very acidic, or just their chemical component will lead to breakdown of the enamel, which will then expose the dentin layer inside. And then that dentin layer is now even more prone to breakdown from the acid and leading to cavities and things like that. So we do not brush her teeth right after giving her the medication. We will either brush her teeth before she takes the medication, or wait at least about 20 to 30 minutes. So same thing that I mentioned with meals earlier. The same rule we follow in case there's a vomiting episode during epilepsy, or acid reflux or anything like that. We don't want to go in. The instinct is to go in and brush right after. Same thing for us as adults. But I suggest either rinsing out the mouth with water, or water and baking soda for us, and then for our children, just waiting about 20 to 30 minutes before we brush their teeth. And bruxism. So bruxism is the clenching and grinding. It can lead to quite a few issues, and we'll talk more about that in detail, but mainly, recession in adults and worn down enamel. When the enamel is worn down, that exposes a softer layer inside the tooth, which is the dentin, which is more prone to cavity development. And next slide there, Janu. So one of the things that many of the parents had mentioned on our Facebook group when I asked the questions about what topics they would like to hear about was that there's a lot of sensory difficulties that prevent them from maintaining regular oral hygiene. So kids, they either gag when you introduce a toothbrush inside their mouth, or the foaminess of the toothpaste itself. So that can definitely be a risk factor for dental disease as well. And prolonged use of pacifier and thumb sucking, that affects the alignment of the teeth and the jaws. If we were to continue that habit beyond the age of 3, that can have some permanent lingering effects that can affect, sleep apnea, breathing pattern. So that definitely is something to consider. You can use those, the pacifiers. I would personally choose a pacifier over thumb sucking. So introducing the pacifier early enough once breastfeeding is successfully established. It is recommended. It tends to lower the risk of SIDS. But beyond the age of 3, that prolonged use is not advised. And as long as we wean them off of that pacifier prior to age 3, then it doesn't tend to have any lingering effects. And the reason I would introduce the pacifier as opposed to thumb sucking is because you can take the pacifier away, but you're not going to be able to take the thumb away, essentially. And risk of falls and facial trauma due to seizures or poor balance, and high risk of calculus buildup if the child does not eat orally, and staining of the teeth due to medications and supplements. Go ahead, Jana, we can load the next slide. Okay. So that's our Joy. She's getting her teeth brushed. So toothbrushing, some tips and tricks is to start early. So we actually recommend starting even before the first tooth appears. You can use a washcloth, a wet washcloth, just to clean their gums. The idea is to desensitize them to having something inside their mouth from an early age, and about two times per day, 2 minutes. Might take a little bit longer depending on your child's cooperation, might take a little bit less depending on the number of teeth that they have. And the biggest thing that really helps me out is that I keep their toothbrush handy everywhere. My kids all have like multiple toothbrushes. We keep them on the main floor, on the top floor, near the change table, near the play area, even the kitchen. So once our Joey, has had her water and things like that in the morning, we're brushing her teeth in her high chair. I can't remember the last time I brushed my kids' teeth in the washroom. It's really difficult to get them to sit still, kind of you're brushing from behind. So I prefer if they're in the high chair or on the change table, or if they're on the floor, where you can have easy access to brushing their teeth. I would recommend using a teether on one side to help keep the jaw open while you brush the opposite side. You can just use a teether, or there's something called the brushing buddy that has varying sizes that would allow different sizes of the opening. One of the struggles that we have with our Joy is that as soon as we put the toothbrush in her mouth, she tends to kind of clamp down on the toothbrush, and then she'll just start chewing it as opposed to letting us brush her teeth. So having the teether on one side lets us really efficiently clean any plaque off of her teeth. Go ahead, Gino, you can load the next slide. Let me know if I'm going too fast, you guys. Okay, so even our neurotypical kids, I typically recommend that they have help from a caregiver until they learn to tie their own shoelaces by age 7 or 8. Prior to that, they just don't have enough manual dexterity to be able to properly clean their own teeth. And we don't have to actually rinse out the mouth after you've brushed the teeth, that you can just wipe it out with a washcloth. Especially a lot of our kids don't have the ability to spit after they're done. So just using a washcloth or a clean paper towel just to clean out the excess, that is fine. That way the fluoride can now sit on their teeth and help remineralize any areas of cavity development. And then flossing the teeth that touch together. So anywhere where the teeth have a tight contact, which typically for kids before the age of 7 and 8 tends to be the back teeth, just taking a little flosser and getting in between the teeth to remove the plaque, that is very helpful for preventing cavities. And again, mentioning, choose a position that is comfortable for your child, is comfortable for you. So here's my little guy, he's 1. He'll let me brush his teeth fine, but I just did this for a demo purpose. I'm using actually a silicone spatula here. So that's fine. I've used that for a Joy previously as well. If you don't have a teether handy, you can use, something that's safe for them, and just to prop their teeth open, and then having his arms underneath my knees there, and he's comfortable, I can see everything, and then just trying to make it fun. That doesn't look very fun right now, but sing a song, make it engaging for them. This is a toothbrush, we're going to brush your teeth, and then they'll be a little bit more engaged about it as well. And go ahead, Gino, you can load the next slide. Okay, so the type and amount of toothpaste that we use, it was recommended a long time ago that we wait until age 3 to introduce fluoride toothpaste. Now, the current guidelines are that we start using the fluoridated toothpaste as soon as that first tooth erupts, which is generally around 6 months of age. The amount really depends on the child's age and their ability to spit. So before the age of 3, just using a small smear, like the size of a rice, even less than that, and using that to brush their teeth, which is really good because typically at that age, they can't spit out, so you don't have a lot to clean up. And then after the age of 3, so even us adults, we tend to use too much toothpaste. Just a pea size is enough after the age of 3. And the way fluoride helps is that it minimizes the risk of cavity development by strengthening the enamel, remineralizing. The fluoride takes the spot of the minerals that are lost from the tooth, and it strengthens the tooth and prevents cavity formation. I know some parents don't like to use fluoride. I won't get into that. But I did want to mention some alternatives to fluoride, which is nano-hydroxyapatite toothpaste. Dr. Jen in the States is a really good brand. And if our kids need something that's, flavorless, SLS-free, sodium lauryl sulfate is the agent that they put in the toothpaste that makes the toothpaste foam. It's not necessary. So if you're looking for something that doesn't foam too much, Dr. Bob toothpaste is really good as well. And Dr. Jen does have fluoridated toothpaste. She has the nano-hydroxyapatite toothpaste, and then she also has a super toothpaste, which has the fluoride and the nano-hydroxyapatite together. But essentially, we need a toothpaste that has a remineralizing agent in there that can help to strengthen the enamel and prevent cavities. Okay, and we can load up the next slide, Jano. Okay, so one of the questions that was asked of me, and I come across this, if not on a daily basis, on a weekly basis in our private practice as well, is why are baby teeth important? They're going to fall out anyways, right? It's true, they will fall out, but they need to fall out at the right time. Our kids by age 2.5, they'll have their full set of their baby teeth, which is about 20. And they're going to have those 20 teeth until age 6, 7, when the baby teeth start to fall out, and then the permanent teeth gradually come into place. The last baby tooth can sometimes stay inside the mouth until about age 12 or 13. So we're in that transitional period where we're going to have some baby teeth, some adult teeth, and the habits that we introduced from early on, habits as parents and for our children as well, the routines that we have in place, it won't, miraculously become change one day. What we start off early on is going to continue later on, which is why baby teeth they're not just practice teeth. We do want to have those habits in place so that way they continue on to our permanent teeth as well. And our kids cannot communicate pain due to dental disease. Cavities can cause quite a bit of pain. They might stop eating as a result of the pain. We can't always see cavities inside the mouth. Sometimes they're only visible on the x-rays. So taking that preventative approach and minimizing the risk of dental disease will really, really help our kids out and help us out as their parents as well, because then we minimize the risk of having to put them to sleep and dealing with that down the line. And infection on baby teeth that can harm the adult teeth. So when the baby tooth has infection on it, the adult tooth is often right underneath it, and then that infection will touch on those adult teeth as well, and which can change the color of the enamel on there. It can change the shape of the tooth even. So we want to prevent that harm to the adult teeth. And they are important for eating, speech, space maintenance for the permanent teeth. If we lose the baby teeth too early, that can cause a delay in the permanent teeth as well. And then the teeth shift, and which leads to malocclusions, which can then, contribute to bruxism, to, again, speech issues, and also to a certain extent to sleep apnea as well, because the teeth, we've lost that arch shape that we were supposed to have. And next slide, Gino. Okay, so ketogenic diet and dental health. Ketogenic diet, generally we're having decreased carb consumption. And that means that the carbs that we are consuming, they're not going to be refined carbs. That a lot of times as parents, we're trying to introduce our carbs from fruits and vegetables. So that does mean that it's limited food source for the bacteria in the oral cavity, which we do see evidence that there's reduced risk of cavities, reduced chance of infection inside the mouth. The diet itself is very anti-inflammatory, so definitely less chronic gum inflammation, that type of thing. It is nutrient deficient diet, so we'll have to see what the long-term effects are of that on the dental health. But we do see less cavities, less gum disease. And one thing to keep in mind is that the higher fat content, it does contribute to acid reflux for a lot of our kids. And the acid reflux is basically, the stomach acid, the digestive acid that's coming inside the mouth, and that can cause erosion of the enamel, which can then lead to cavities on the dentin and sensitivity in general. But in general, we see less cavities, less gum disease as a result of being on the ketogenic diet. Some patients have reported halitosis, which is a fancy word for bad breath, and that does tend to subside over time. And next slide, Gino. Okay, so teething and seizure control. Some parents do report loss of seizure control or increased seizure during teething episodes. Fever can be a trigger for that. And another thing to keep in mind is that dental trauma during falls or seizures can affect baby teeth and adult teeth. That we've seen cases of where the teeth are fully avulsed out. Please keep in mind that baby teeth cannot be put back into the socket. Adult teeth can be if the adult tooth was lost as a result of the trauma, and don't touch the root just by holding on to the crown. It can be placed back in there. If you don't feel comfortable doing that with the adult tooth, I suggest putting the tooth in some milk and just taking it to your dentist or pediatric dentist and having them put that back in there. But baby teeth should not be put back in, even if the root is fully intact. And next slide, Gino. Okay, so this topic is, we're going to talk about this quite a bit. So clinching and grinding, another word for that is bruxism. There are many different causes and triggers for that. So similar to how epilepsy is only one symptom of CDKL5, bruxism can be a symptom of many different conditions. And we see it more commonly in certain types of epilepsy, especially temporal lobe epilepsy. There's been some links between sleep apnea, airway issues, and bruxism. Anxiety and stress can be a contributing factor as well. Certain medications increase the risk of clinching and grinding, certain anti-epileptic medications, ADHD medications, antidepressants. We know that once the patients are on them, they are going to be more likely to clinch and grind their teeth. Misaligned teeth, when there's malocclusions where the jaws don't close in their proper position, that is also going to contribute to bruxism as well. Certain vitamin deficiencies, magnesium, calcium, vitamin D, they also contribute to clenching and grinding as well. And I came across this recently, parasites, so pinworms. Apparently, if you have that, that can also lead to bruxism as well. So for a lot of our kids, it will be more so the type of epilepsy and the medications, sensory issues, that is what tends to contribute to that for our kids. Some signs and symptoms to watch out for, things that I watch out as a healthcare provider is, just talking to the patients as well. So the parents will know that their kids are clenching and grinding because we hear that sound. Some of the symptoms that our kids may not be communicating to us is that it can cause a headache, neck ache, jaw pain, earache. We'll watch out for flattening of the teeth, wear facets, which are basically holes on the back teeth where the top and bottom teeth kind of fit together, and they're causing wears into the chewing surfaces of the teeth. We'll watch out for chipped and fractured teeth or previous dental work. And clicking and crackling in the TMJ joint right here, the TMJ, and recession of the gum line and exposed roots, tooth sensitivity, and an indented tongue from where the tongue is pushing into the teeth as the clenching and grinding is happening, and also poor sleep as well. Poor sleep will contribute to clenching and grinding as well. And next slide, Gino. Okay, so the Treatment and prevention strategies for bruxism. Again, it depends on the root cause of what is causing the bruxism in the first place. So one of the first things we recommend is assessing for airway issues and sleep apnea. So sleep apnea is essentially where at nighttime, the child or even adult, they're not able to breathe properly. They're getting either central sleep apnea, which happens here, or obstructive sleep apnea, which happens here. Their brain is not getting enough oxygen. So what the body is doing is the jaw is being moved side to side or forward in order to enlarge that space to try to get some air in. That's how bruxism and sleep apnea are linked together. So definitely, talking to your pediatrician, getting a referral for a pediatric ENT to assess for those issues to see if that is something that could be contributing to that. Sleep apnea, we know it can lead to a lot of chronic diseases over time, cardiac issues. So we do want to address that and make sure that that doesn't contribute to the cardiac issues and things like that. And if the reason is malocclusion or misaligned teeth, then we want to have a consultation with orthodontics, an orthodontist, to see if that is something that can be corrected. A lot of our kids, they may not be candidates for this type of treatment because, again, for compliance and being able to cooperate during the visit, a lot of times for orthodontics, you're going in for a checkup every 4 to 6 months. We need to keep the brackets in place, and our kids simply won't be able to have those brackets placed because they won't be able to sit still for that type of treatment. And mouth guard. So the mouth guard, which is a night guard appliance that you wear at night, it doesn't stop the bruxism from happening. It only prevents the damage to the teeth. So again, for our kids, compliance would be an issue, and it's not recommended for growing individuals because it can constrict the growth of the jaw as well. Botox, which is the temporary paralysis of the overactive muscles of the masseter right here. Again, being able to sit still long enough for that, some of our kids might not be candidates for that. What I would recommend is, working with your SLP, your speech language pathologist, or your OT, focusing on desensitization. I know for my daughter, what helps her out is if we do give her like a teether, a chewing toy that helps her to kind of work through those muscles, so that way the damage isn't being done to her teeth. So that really helps. That could be a goal for some of our kids with their care providers. And something to look into is also myofunctional therapy, and they would use the MyoBrace for the obstructive sleep apnea. But again, a lot of it, the treatments, it comes down to them not knowing to sit still through the treatment, and also the compliance, because a lot of them rely on using braces or mouth guards of some sort that they won't be able to wear. And next slide, Gino. So I did want to take a few minutes and go over caregiver dental health as well. A lot of times that we're so busy looking after our kids and we're always just giving, and we tend to put ourselves last. So I did want to take a few minutes and go over what we can be doing as caregiver to decrease our risk of dental disease as well. Because if we're taking care of ourselves, then we can then give to our children or our family. So brushing twice a day for 2 minutes with a soft bristle toothbrush or an electric toothbrush. Once you brush your teeth for nighttime, I recommend water only, nothing after that. And if you tend to brush very aggressively to the point where you're causing recession in the gums and things like that, try using an electric toothbrush or your non-dominant hand to relieve some of that pressure as you're brushing. And then flossing or using flossing picks. And then if you're more prone to developing cavities in between the teeth, you can actually take your piece of floss and put some fluoride toothpaste on it, and that will help to prevent or remineralize any of the smaller cavities in between the teeth. And if you struggle with halitosis, bad breath, definitely recommend using a metal U-shaped tongue scraper. Start from the back and then go forward a couple of times. That will help to remove quite a bit of the bacteria buildup in our mouth, and that is a game changer. And different mouthwash options depending on, if you're fighting bad breath. TheraBreath is an amazing alcohol-free mouthwash, and OptiRinse is a really good over-the-counter one if you're at a higher risk of cavity development. And I don't recommend using toothpaste or any dental products that have whitening components in them or charcoal ingredients, because they tend to be too abrasive. They help initially, but then essentially they're wearing down your enamel, and then we end up with actually yellower teeth and more damaged teeth over time. So definitely a no-no when it comes to whitening toothpaste, charcoal toothpaste. I would say definitely stay away. And avoid mouthwashes that contain alcohol. So alcohol is a drying agent, so we end up with drier mouth, and then that contributes to cavity development. So always use mouthwashes that don't have any alcohol in them. And recommend using a night guard appliance if you're prone to clenching and grinding. You can go through some of the treatment options that we shared earlier under bruxism, but if it's one of those things that it's very much induced by stress and anxiety, and it is a difficult habit to break, that clenching and grinding. So of course, meditation, yoga, that will help as well. But in the meantime, definitely recommend using the night guard appliance so that at least we're preventing the damage to the teeth. And regular dental visits, going in every 3 to 6 months. The goal here is to identify small problems and prevent them from getting larger, or treat them at the smaller stage, as opposed to delaying until we have a toothache or larger issues. Then the cost goes up, and of course the treatment becomes more invasive. And next slide, Gino. Okay, and then we can load all of those up. I just want to make sure I covered everything.
Oh,
I think there's some questions there, but mostly I talked about everything. Yeah, that's good. Any questions, anyone?
so there are questions on the chat. The first one being, my son will be 1 year old soon.
Mhm.
He loves his pacifier.
Mhm.
Is there any specific type of pacifier which is better for older child?
Definitely. So the shape of the pacifier does matter. I can share a link to this SLP that I follow on Instagram, and she talks about the different shapes of the pacifiers. There are some that are very round, that is going to cause more constriction. It comes down to tongue positioning. The one that allows them to place their tongue in the proper position, which is the roof of the mouth, that's going to cause less of an issue with restricting the growth of the jaw. But, in that early age, a lot of the changes to their teeth, their jaw, they will get better. I would recommend weaning off of the pacifier by age 2, 3, if you can. It's a great soothing, tool for our kids. And a lot of times when they're getting those blood pokes, it shows that it also helps with providing pain relief as well. So I'm not against it, but definitely there are some that are better to prevent the damage to the teeth and the jaws.
Thank you. The next question is there any correlation, or do we know that tooth sensitivity is aggravated with CDKL5 or other rare diseases or autism? Like, because children tend to not like when we brush, and that's a little more than, other children.
Mm-hmm. I wouldn't say it's necessarily sensitivity. I would say it's that the sensory component, that they don't like to have certain textures of foods. They don't like to have the toothbrush. It's the bristles of it, right? So definitely using a soft bristle toothbrush is really important. I would say it's more of a sensory thing as opposed to sensitivity. One thing to keep in mind is that clenching and grinding of the teeth can cause a lot of pain in the jaws. So our kids can't communicate that to us, but we do see adults that come in where there's no issues, and the only thing that we can identify that could be contributing to the sensitivity is the clenching, the aggressive clenching and grinding of their teeth. So that's one thing that will contribute to the sensitivity for our kids. But I wouldn't say that their teeth are necessarily in pain when we're trying to brush them. We just need to, you know, kind of work to desensitize them off of that. So giving teethers, the teethers will naturally help to kind of clean their teeth as well, and letting them get used to the sensation. Let them hold the toothbrush as well. Don't let them walk around with it, because a lot of injuries can happen that way. But if they're in their high chair, let them hold the brush, give them a brush to hold in their hand while you're working with one, just to kind of keep their hands occupied. And I think that will help to desensitize them over time.
Yep, thank you for that. There was one more question, and that's actually like for mouthwash. And so recently there were some publications which talked about mouthwash and its impact on the good oral bacteria as well. Like, so what is the fine line we should draw between using? And this is for more of caregivers, and I'm glad you touched on that topic, so thank you.
So mouthwash itself is not going to prevent dental disease. So, you know, I've had patients where they don't brush their teeth, but they think swishing with the mouthwash is enough, right? And then out they go, right? It's like showering, not showering and putting on deodorant, and you think you're good to go, right? So the main thing that's going to prevent dental disease is removal of the biofilm, the plaque that's sitting on our teeth. So that's going to be the brushing, the flossing, using the tongue scraper, bringing the bacteria load down. If you're using a mouthwash that's targeted therapy, like for example, you struggle mainly with bad breath and that's what you're trying to target, then it's helpful to introduce that mouthwash as an added technique. But definitely, you know, even antibiotics, right? They're known for wiping out good bacteria and bad bacteria, but at times they're necessary to treat the things that we need to use them to treat. So same thing with the mouthwash. Definitely, you know, I haven't come across that, but I imagine if it's taking away the bad bacteria, it's also taking away some good bacteria that's in our mouth. You don't have to use a mouthwash. It's not a necessary step of an oral care, in my opinion. But if we're targeting particular things, for example, patient that's more prone to cavity development, then we want to use a fluoride mouthwash. Someone's undergoing you know, radiation therapy near the face, jaw, and we're worried about dry mouth and increased risk of cavity development. Someone who's on multiple medication will naturally have a drier mouth. Then we can introduce those to decrease their risk of cavity development.
That makes sense. Thank you. What are the black honey color spots where the teeth are not fully developed yet?
What are the black spots on the teeth?
Yeah, like this. Yeah, so
On the
black
gums.
spots, like honey color spots, honey-like color spots that show up on the teeth when they're not fully developed yet.
On the gums, you mean? Or
On the
spots are
teeth. The
appearing on
question says on the
on the gums? So
No, it says on the teeth. Yeah.
honey colored spots that are on the teeth that are not fully developed.
Yes.
I think we might be talking about like discoloration of the teeth as they're coming inside the mouth.
Yeah, not on teeth. Sorry, on the gums. Yeah.
On the gums, okay.
Yeah.
So
Sorry. Yeah.
I'll cover both just in case. So gums, before the tooth comes into place, or that area can be, you know, highly vascularized. Sometimes there's something called eruption cyst, which can be like a bluish bump on the gums. And then once the tooth breaks through, then that all clears up. So that's all part of the eruption pattern of the tooth. Doesn't always have to be there, but definitely it's just the tissue that's covering the gums there. Teeth can come inside them as they're coming out, depending on the oral environment. They can have changes to the enamel texture, could have been developmental. There are certain diseases inside the mouth that affect the development of the enamel, development of the dentin. So that could be something to watch out for as well. It's very rare. And also cavities, when they're first forming, they do turn the enamel more white in color. So if you're noticing in certain spots, especially at the gum line, that your kids are developing, like all of a sudden is turning very chalky white. That is demineralized enamel. Eventually that enamel will chip off and it'll turn into like a full-blown cavity. So recognizing that as an early stage of a cavity and having your dentist apply like fluoride varnish, that will help to remineralize that area and prevent that enamel from breaking.
I hope that answers the question. Ashwant, if not, then you can just add it to the chat and we can clarify more on that. The next question, Dr. Grewal, was any tips on helping kids get X-rays and dental work? What are some of the epilepsy safe sedative options?
Good question. So if we're talking about them having dental work done while they're awake, so for our children, it's a wide spectrum of how much they can cooperate, how much they understand when we're talking about dental visits. So trying to keep them, like happy during that visit is really important. I think connecting with the right provider, whether it's the dental hygienist, the dentist, the dental assistant, someone that they feel comfortable with and connected with is really important. There are times where, if a child can't take an X-ray, where I stood there holding the X-ray sensor and then we take the X-ray. But not being able to take an X-ray during a checkup is a really good indicator of whether the child is going to be able to sit still through the actual treatment. So if we know there's known dental issues and we can't even take an X-ray, whether the child is crying or they just don't understand how to close down on the sensor, then very likely that child will need some form of sedation in order to have the dental work completed. I know that for when we bring our Joy into the dental visits, she wants to bite down on everything. She's bitten our hygienist a few times. So for me to take something like a drill, something sharp inside her mouth and think I can do dental work on her, that's very unrealistic. That's very unsafe for her, for me. We use a lot of small little things. So risk of her choking, aspirating something is really high. So as much as I would want to do the dental work for her, I know that if she ever needs dental work done, she will likely need heavy sedation in form of either like deep IV sedation or full sleep dentistry, general anesthesia in order for her to have the work done safely. And so that would be done in a hospital setting or a pediatric dentist. So that's why I talk a lot about prevention, because that's a very scary thought. As a parent, that would be really scary for me to take her in and have her put to sleep for something that doesn't need to happen, right? So there are, and I don't mean to say that as a way of shaming anyone. Like I want to assure you that, my oldest has had a cavity, right? She's had to have a cavity full, like a dentist child has had a cavity. It happens. We do our best every day. But when it comes to preventing these things, we can take charge and we can prevent them from getting to that stage. And sometimes we do everything right. We do everything by the book. And like we talked about, there's multiple things that play into it that leads to, cavities, rampant decay. It could be that our children are hospitalized and, teeth are the last thing we're focused on. Dental damage happens from falls and things like that, and they might need a dental surgery. So when it comes to safe options, I will look at a pediatric dentist for sure. I would go to a pediatric dental office where they offer dental anesthesia with an anesthesiologist, or a hospital setting where they're able to completely put her to sleep and do the dental work for her. Unless it's something really minor, I would not, if it involves numbing her, drilling something, I would not do that for her in our office. For children that have better cognitive understanding, where they can follow instructions that when you say stay open, sit still, and you can actually use behavioral management techniques with them. Something like nitrous oxide, where they're breathing through the nose, they have like a little mask over their nose, that keeps them calm throughout the treatment. Then you can get some work done with that as well. I've worked on kids as young as 2 and 3, where they can cooperate throughout that treatment. This is actual dental treatment. And then I've also seen, some adults who can't sit through the treatment and they need to have sleep dentistry. So it varies on the child's ability to cooperate.
Yeah, no, that's very insightful. Thank you for that. The other next question that's coming in is, our kids are not able to spit while brushing. Any tips on how to minimize the amount of,
What
fluoride they consume? And
Yeah.
is the pea-sized toothpaste safe for them to swallow in long term? Yeah.
For long term, the pea size for our kids, so Joy's 5, I still use a rice size amount for her, for that very reason, because it's less of it for me to clean up. I would shy away from using the pea size. That's more for, sorry, I should have clarified that when I talked about the amount of toothpaste. That's more for the guideline for neurotypical children. I came across some calculations for the rice size amount. Apparently, when you look at the amount that's in that rice size twice a day, it works out to be less than what's in their daily formula consumption. So there's naturally some fluoride in, formula as well. So that I would say long term, to me, that's fairly safe. And the pea size, I would only use if the child is able to spit out. I should have clarified that.
And yeah, so we are at time, but I have so many more questions. But this
You can message
this-
me.
yes, this was amazing. Thank you so much, and
You're so welcome.
we really appreciate it.
Thank
all
you
the
for
insight
giving
from
me
you.
the opportunity to talk about 2 of my favorite topics, which is CDKL5 and teeth.
Yeah, thank you.
Okay,
Thank you
thank
very
you,
much.
everyone. Take care. Bye.